The uterine tubes, fallopian tubes, FT, are too hollow. Muscle mucosal. Organs, about 10-12 cm long, divided into 3 portions: the intramural, the isthmic, and the ampullary. Ones, this last portion terminates in an enlarged end, called infundibulum, with some protrusions called fimbriae. The ovarian fimbria, in particular, is connected through the mesosalpinx to the ovary. The tubal ostium laterally is the site where the tubal canal meets the pelvic cavity, while the uterine opening of the FT is the entrance into the uterine cavity, the uterotubal junction. As the cervix and endometrium, also the FT are derived from the Mullerian ducts. The wall of the tube has a mucus layer and a muscle one, thicker in the medial part of the tube. The contraction of the muscle bundles allows the tubes having their own peristaltic motility. The mucosal layer is covered with cells, some of which ciliated, that determine a bidirectional internal movement of fluids and cells both to the uterus and towards the pelvis. The production of cilia on these cells is increased by estrogens. Scattered between the ciliated cells are secretory cells, which contain apical granules and produce the tubular fluid. The number of these cells is increased by progesterone, while estrogens increase their secretory activity. The tubal fluid contains nutrients as lipids and glycogen for spermatozoa, oocytes, and zygotes, and also promote capacitation of the sperm. After ovulation, physiologically, the oocyte is caught by the fimbriated end and travels to the ampulla of the uterine tube, where the sperm are met and fertilization occurs. The fertilized ovum, now a zygote, comes towards the uterus. Thanks to the activity of tubal cilia and muscle, after 4 to 5 days the embryo reaches the uterine cavity, and on about the 6th day, implants on the wall of the fundus of the uterus. Given their bidirectional motility, moreover, the FT are able to let cells, pathogens, blood, and substances from the vagina, the cervix, and the endometrium to reach the abdominopelvic cavity. Benign tubal pathologies as indication to salpingectomy. Inflammatory diseases are the most important tubal disorders. Due to their frequency and their consequences, sometimes serious, FT indeed, placed between the uterus and ovaries, are frequently infected by one of these two organs. The communication with the peritoneal cavity, moreover, exposes the tube also to any abdominal infection. Appendicitis is a frequent source of descending infection. Rarely, the tubal infection is transmitted by blood, as in the case of tuberculosis. Salpingitis. More often, the infectious processes ascending from the lower genital tract extend to the tube and reach the peritoneal cavity, leading to pelvic inflammatory disease, PID. The narrow tubal lumen undergoes important consequences. In case of inflammation, the mucosal edema can completely occlude the uterotubal junction, preventing drainage of inflammatory secretions in the uterine cavity. This causes the onset of acute salpingitis, in which the tube is red, swollen, tortuous, with thickened wall in the lumen filled with pus. The progress of each salpingitis is very slow. Exceptionally acute inflammation can heal spontaneously, and the restoration of tubal anatomy and function occurs. Usually, however, the infection becomes chronic and causes permanent tubal occlusion. The tube becomes more dilated, takes the form of a sausage, and is filled with pus, leukocytes, or plasma cells, hydroalpinges. The drainage of this infected tube into abdominal cavity can cause the insurgence of peritonitis. The purulent content may gradually melt, turning into a serous or serohematic fluid, hydroalpinges or hematosalpinges. This conditions can remain asymptomatic for a long time, and the diagnosis is often difficult or accidental. When salpingitis becomes chronic, the peritoneal adhesions surrounding the tube and ovaries distort the course of the FT and cause infertility. In tubal factor infertility, when the cause is bilateral, hydroalpinges, in vitro fertilization (IVF) is now considering the first option rather than attempting to restore tubal function. The hydroalpinges themselves, however, adversely affect IVF outcomes, reducing the implantation rate and increasing the risk of miscarriage. Among the pathogenic mechanisms proposed, embryotoxic effects, mechanical flushing, and changes in endometrial receptivity are the most shared by reproductive gynecologists. The hydroalpinges fluid, indeed, is able to reach the uterine cavity, in which embryos try to implant, and exerts a toxic effect on this delicate phase of pregnancy. Laparoscopic salpingectomy has been demonstrated to be an effective option for avoiding this negative reproductive interference, improving pregnancy rates and removing the risk of PID and ectopic pregnancies whenever laparoscopy is not recommended due to the presence of dense pelvic adhesions. Hysteroscopic insertion of device seems a very effective option for management of hydroalpinges before IVF. Recently, a systematic review and meta-analysis of studies comparing the pregnancy outcomes in hydroalpinges patients treated with salpingectomy versus those treated with proximal tubal occlusion prior to IVF has been published. In this study, comparable responses to controlled ovarian hyperstimulation and pregnancy outcome were observed between groups, demonstrating that salpingectomy does not worsen reproductive prognosis of patients in which excisional surgery is chosen. Hydroalpinges is also the most frequent, 35.5%, complication of the blind-ended remnants of the FT in patients undergoing hysterectomy with tubal preservation. Others pathologies that may emerge from retained FT are tube prolapse, torsion, PID, benign and malignant fallopian tube tumors. Other frequent causes of peritoneal adhesions responsible of anatomical and functional FT alterations are previous pelvic and abdominal surgeries, especially if performed by laparotomy, cesarean sections, surgeries for uterine myomas, or ovarian cysts, but especially the presence of peritoneal or ovarian endometriosis are well-known risk factors for tubal alterations and occlusion. Many variables have to be considered when counseling patients with tubal alterations regarding corrective surgery or direct IVF, the chronological and ovarian age of the woman, the site and extent of tubal pathology, the semen analysis of the male partner, the presence of other infertility factors, such as ovarian endometriosis, the experience of the surgeon, and the quality and success rate of the referring IVF center are the most important, given the costs and benefits associated to both surgery and IVF. The ideal candidate for surgical tubal restoration is probably a young woman with no other infertility factors, a partner with a normal semen analysis and a tubal anatomy amenable to repair. Conversely, patients with extensive omolateral dense peritubal adhesions from endometriosis and or dilated tubes, 3 cm with thick fibrotic walls have poor prognosis. In all these cases, the tube is usually damaged beyond repair, and omolateral salpingectomy is indicated when pregnancy can be achieved by spontaneous attempts in patients with tubal factor infertility. However, IVF has a higher pregnancy rate per cycle, and this information need to be discussed with the patient to provide assistance in her decision-making. The second most frequent benign condition affecting the FT is the ectopic pregnancy, EP, between 1 and 2% of live births in developed countries, and as high as 4% of pregnancies involving assisted reproductive technology are complicated. By EP, in which the embryo is implanted outside the uterine cavity. At least 93% of ectopic pregnancies are located in a FT. Of these, 75% are located in the ampullar portion, 13% are located in the isthmus, and 12% in the fimbriae, but ectopic implantation can also occur in the cervix, ovaries, and abdomen. EP can be a life-threatening condition, as it is responsible for 6% of maternal deaths during the first trimester of pregnancy. In a typical tubal pregnancy, the embryo adheres to the lining of the FT and burrows into the tubal wall. Commonly, it invades vessels and causes intratubal bleeding, which may discharges the implanted embryo out of the tube as a tubal abortion. Sometimes this bleeding might be heavy enough to threaten the life of the woman, even if, in developed countries, this event is today luckily rare. Identified risk factors for EP include PID, infertility, use of an intrauterine device, IUD, previous exposure to toxicants, tubal or intrauterine surgery, smoking, previous EP, and tubal ligation. Fertility following EP is dependent from several factors, the most important of which is a prior history of infertility. The treatment choice seems not to play a great role. Recent randomized study concluded that the rates of intrauterine pregnancy 2 years after treatment of EP are approximately 64% with excisional surgery, 67% with methotrexate, and 70% with conservative surgery, salpingectomy. In a new open-label, multicenter international randomized controlled trial, women aged 18 years and older with a laparoscopically confirmed tubal pregnancy and a healthy contralateral tube were randomly assigned to receive salpingectomy or salpingectomy. In this study, the cumulative ongoing pregnancy rate was 60.7% after salpingectomy and 56.2% after salpingectomy, difference not significant. Between groups, persistent trophoblast, however, occurred more frequently in the salpingectomy group than in the salpingectomy group, 7% versus 1%. Repeat ectopic pregnancy occurred in 8% of women in the salpingectomy group and 5% of those in the salpingectomy group. The number of ongoing pregnancies after ovulation induction, intrauterine insemination, or IVF did not differ significantly between the groups. Meta-analysis of data substantiated the results of the trial, so that authors concluded that in women with a tubal EP and a healthy contralateral tube, salpingectomy does not significantly improve fertility prospects compared with salpingectomy.